Good evening, everyone, from wherever in the world you're watching us. We bid you welcome. Welcome to the fifth in the series of the quarterly public education webinar for the Restore Foundation for Child Sight. Today, the topic will be taken by the erudite Professor Dupe Ademola Pupola. The white glowing eye may be a deadly cancer. So this will be a focus on a disease called retinoblastoma. So retinoblastoma, just as a summary, is the commonest eye cancer in childhood, and it may manifest in different ways in early phase. It may lead to loss of sight or loss of life. So this is an important thing to be talking about. And the eminent personality who is here with us today, no one better qualified to talk about retinoblastoma, is Professor Dupe Ademola Pupola. This is a very, 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 very short biography, as short as we could make it. She's a medical doctor by training, gained her MBBS from the University of Lagos in 1991, and then subsequently undertook her specialty training in ophthalmology at the University of Ilorin Teaching Hospital, gaining her fellowship of both the West African College of Surgeons and of the Faculty of Ophthalmology of the National Postgraduate Medical College over 20 years ago. She subsequently subspecialized in pediatric ophthalmology, training in the famous L.V. Prasad Institute of Ophthalmology in India in 2007, and subsequently also obtained a specialist training oncology fellowship in 2009. She's been a consultant ophthalmic surgeon for over 20 years, about 22 years now, and also in the pediatric strabismus and oncology services of the University of Ilorin Teaching Hospital. She's a professor of ophthalmology of the University of Ilorin. And she's a director currently of the Computer Services and Information Technology, also of the University of Ilorin. And she's a global advisor of the American Academy of Ophthalmology. So she's very well recognized internationally. She's a principal investigator and project coordinator for grants for University of Ilorin since 2016. And she's been the past head of Department of Ophthalmology in the same university. She's been a past chairman as well of the Nigerian Pediatric Ophthalmology and Strabismus Society, NIPOS, for 4 years, from 2014 to 2018. And she's also served in the position of faculty secretary of the ophthalmology of the National Postgraduate Medical College of Nigeria. He's a zonal coordinator also of the Ophthalmological Society of Nigeria, and she's part and parcel of many groups involved with various pediatric pathology, eye pathologies like retinoblastoma we want to talk about today, prematurity and its eye complications, and many more groups. She was principally instrumental to the enactment of the Child Eye Health Bill in Kwara State. And Kwara State till date is the only state in the country that has a Child Eye Health Bill legislated. And she was the principal person who instrumented this. She's also the proponent of TELVIS, the teacher-led visual screening in school eye health program, which has led to successful screening of thousands of school children, early detection and treatment of eye conditions to ameliorate visual impairments. She has several publications on retinoblastoma, today's topic, and many other topics relevant to pediatric ophthalmology in both local and international journals, and herself a journal reviewer for local and international journals. She's a trainer of various groups of people, from medical students to ophthalmic residents to pediatric ophthalmology training, and she's married to Professor Ademola Pupola, so they're academic heavyweights, a consultant in urology, and she's got 3 adult children, and this medical thing flows in the family. Got 2 of her adult children are medical doctors, and her baby is currently running a doctoral program in the US. So we have before us, an Amazon, a heavyweight, and so I present to you everyone, Professor Ademola Pupola Dupe, the clinician, an academic, a trainer, a mentor, a researcher, an inventor, and the list is endless. I picked these ones. I'm sure there are many other things, positive things that she is. So thank you very much. We're honored that you can join us today for this lecture. So I will stop sharing my screen now so that Professor Pupola can take over. Thank you.
Wow, thank you so much, my dear sister, Dr. Halima Alimi. It's always a pleasure to be with you. It's been a long way we have come, and I'm very excited to be here to take this white glowing eye that may be a deadly cancer. I want to acknowledge everyone here I have seen Dr. Logbon, with whom we also have come a long way. Akinremi, Nana, I've seen quite a number of people here. Thank you for joining us this evening. I recognize and acknowledge everybody that I can be looking through this participant list. Thank you so much for joining us. So, because this is an open meeting, we would talk about the eye in general for context. It is important that we all know that the normal position of the eye is for the eye to be straight. When we're not sleeping, the eye should open well, should be steady, to be central, to be normal size and equal in the right and left. The color should be correct for your race and the vision should be clear. Let's remember that if anything happens to any part of this description, then there's a problem. Because you also want to bring understanding to this subject matter, I just want my listener to recognize that the eye pretty much is where the camera derives its function and builds. There is an axis through our eyes where vision actually subserves. We actually look through our eyes and invariably the brain helps us to see. But for the brain to be able to see, the eye has to be normal. Every part of it that ought to be clear from this front part that we call, excuse me, let me get my pointer. From the front part that we call the cornea, in the regular human eye, it looks like it is brown, but it's not. It's really transparent. What makes it look like it's brown is our iris that gives us the color that makes someone's eye to be blue or brown. For most of us, it will be brown or chocolate brown. So from this cornea, light will go through the lens, which is transparent, and we go to this sensitive, the most sensitive part of the eye, transparent, that is called the retina. And from the retina, vision gets transmitted to the brain and then we see. So we're going to be looking at a few conditions that may affect different parts of this eye, and then we will come back to talk about retinoblastoma. But I want us to realize that this transparent part that I'm also showing on this one on the right, this place is at the areas where retinoblastoma affects to cause the problem it causes. So now, I have put here a few conditions that may confuse an ordinary person, but whatever the case may be, none here is actually expected to be normal. Remember that it's different from the very first picture that I showed you. In this child on the uppermost left of your screen, you can see that you can see a whitish reflex from the eye. Normally, our eyes will look a bit dark. If you shine light, it will come as red to you. But when you have it white from whatever cause, it is an abnormal condition. This first one was a child who was born premature. Because the eyes were not examined, she became blind in the first 6 months of life. The second one, you will see that that outermost part that I said is usually transparent is the one that is affected, the one we call the cornea. It's hazy because the pressure in the eye is high, and this was caused by glaucoma. This third one, upper right, is caused by cataract. Just like we have cataract in adults, we can also have in kids and children. In this lower one, the iris that should ordinarily be brown is the one that doesn't have enough pigment and that has caused this whitish reflex that we're looking at. While the middle lower one is a scar on that same cornea caused by trauma. But when you look at this lowermost right, you will see that there is a glow. It's brighter than the rest of them. So this is the subject matter of today. Also, it's in this eye condition that we say not all that glitter is gold. When the eye of the child, you know, in Yoruba land, they use eye to describe people. They can say the eyes are big. They say it in a positive way. The eye is glowing, you know, that kind of a thing. But if the eye is glowing in a child, it's a sign that there is problem. And so we'll be talking about this condition that may cause the eye to glow, which is abnormal, and it may in fact be deadly. And this is called retinoblastoma, as has been explained earlier. I will just try to speak to this now. It is actually the commonest cancer of the eye. Hello? If we put both adults and children together, even in the whole world, even though in some part of the world, there's something we call melanoma that is common in adults, it's not so common with us. It has been found that this cancer is actually the commonest eye cancer. Now, it develops from that inner sensitive part of the eye. I'm showing that again. And it usually affects both boys and girls equally. And typically they'll be under 5 years of life. And it actually has been reported rarely in adults. About 49 adults have been reported to have retinoblastoma for the first time, but it's not common in adults. It tends to affect 1 out of every 15,000 children born alive. So we can figure it out. If you can imagine that in our cities, in my hospital, we have about 400 new babies born every year. You can imagine if 10 hospitals come together in a city, and then in the next city, you can have an idea of how many children may come up with retinoblastoma. But suffice for us to say that we expect about 339 cases every year from Nigeria, from what our birth rate looks like. And it can affect the child from the womb. Before the child actually comes out, retinoblastoma could have affected the child. But in many instances, they are discovered from the first month to the first 2 years of life. Now, if you look at the picture on this right side, you will see that the first picture, the uppermost left picture, seemed to show that the eye was normal, when in fact it's not normal. But when we examine very well into the front of the eye, towards the front of the eye, that cancer showed up. Again, it's one that is being shown on the lowermost part of the eye. So typically it starts small, and it can be multiple in one eye. One eye can have many as 9 tumors can be there. The other important thing to note is that it can occur in both eyes. It may affect one or both eyes. When it affects both eyes, usually they show before the child turns 1. And typically they will show in the first 6 months of life. And when both eyes are affected, one would usually be a small tumor like we're seeing here. This lower one, these lower 2 images showing this small tumor. And the other eye, we have a large tumor like we can see in the upper right picture. That is very important. So it's not surprising for patients to come and say, my child has problem in one eye. We always have to check the other eye. And this is so important because you can imagine that if there's a tumor in one eye, as far as the parents is concerned, and the doctor does not know of the importance of checking the other eye, or does not know how to check the other eye, and you give false hope, that child is going to go from, you think that you're looking after this tumor, this other one will now be growing under. And before we know it, it also takes over the whole eye, and then the child loses both eyes to the tumor. So it's very important that we must emphasize the fact that when it occurs in a child, especially those who are less than 1 year, both eyes are typically affected. The other eye may not be present the same day the first eye has the tumor. So when that child comes to us, we look out for, what is it called? For the tumor in the other eye, but we then inform them that, come, today I can't find tumor in the second eye, but I know it can come up in the course of follow-up of this child. So it becomes important that that child continues to be seen in clinic. How does it come about? What causes it? I'd just like to bring us into some understanding about the uniqueness of each one of us. There's something called the gene, the basic human heredity building block. What makes me me? You, makes us to look alike in our family, and you look also like other members of your family. They are because you have unique genes. They are found in our chromosomes, and there are over 20,000 of these genes. The genes, they are responsible for our heredity, the things we pass on from generation to generation. They actually determine our growth, our development, and our physical characteristics and traits, like the color of our eyes, sometimes the way we behave, the sort of diseases we succumb to sometimes. So retinoblastoma occurs because there's a problem in the gene. The gene is called RB gene. For short, RB is retinoblastoma for short. So the RB gene actually, when it is normal, when there's no problem with it, is called a tumor preventing gene. We call it in medicine tumor suppressor gene. When it's normal, it fights against the development of tumor. It doesn't allow a tumor to occur. But when there's a problem with that gene, then that child becomes susceptible to developing this cancer. And in fact, it's so important because it's the first gene related to cancer that was determined. And this gene gave a lot of insight into how other tumors, especially tumors affecting the brain, develops. So how does it show itself? When a child has retinoblastoma, how would we know? We've talked about the glow, but that is not the only thing. Before the glow, sometimes you may find out that the child has a squinting eye that we call strabismus. The eye may turn inwards or outwards. In my experience, most of such eyes, they turn inward. But I must sound a note of warning. It's not every child that has an eye turning inward that is caused by retinoblastoma. But because we don't know, if that child's eye turning inward is from retinoblastoma, that's why every child that has an eye turning inward must be examined to be sure that this cancer is not present in the eye. Because really, if we pick this disease at the stage at which the eye has just turned inward, it's a good sign that we're picking it early. But when it starts going to this glow that we talked about, that tells us that, oh, the tumor has become large. It's reflecting. It's bouncing back at us, you know? So how can we find this? You find out that you take a picture, especially in the dark, and then it returns with a glow, like the glow that we show in that original picture we started with this one. If you take a picture of a child in the dark, or the child looks and it looks like a cat has just passed before you, most likely there is a problem. If you check the day after, you still find it there, please ensure that you get a place where the child can receive the most needed help. Sometimes it is an accidental finding. Sometimes you're looking for something else in the child, and then the health worker notices it. So it can be found like that. In other climes, children have regular check during what they call well baby clinics, including checking for the eyes, the hearing. And so they look out, people look out for all these problems, and then they detect them early. And that is the reason why in those parts of the world where this is regularly done, almost all children who have retinoblastoma will be picked early, and then they are likely to survive. Health workers, during immunization, if they have learned to look at the eyes of children or in well baby clinic, they may find the retinoblastoma. So if retinoblastoma is present in an eye, how does it progress? I just mentioned that it goes from this squinting eye. It's not all children that will have squinting eye. We should also remember that, because it depends on where it is seated on that retina that I showed. It could go straight to become this whitish glow. From this whitish glow, some of them will cause the eye to shrink. And that will be, of course, once the eye is shrunken like I have here, that will be the end of it. Or it can go from this whitish glow. Nothing is done to prevent the disease from advancing. Remember, it's a cancer. It keeps eating up the body. It eats up everything. It takes all the space and starts spreading itself into other places around. That is the point at which it becomes like what we have in this picture, pushes the eye out, by getting to the back of the eye, it arborizes there, grows there, and then goes out to push the eye out. We don't do anything about it. We start looking for the eye completely like in the lower picture. If we leave it still, it spreads from the eye to the brain and to other parts of the body. You can imagine from this picture the kind of pain that child went through. So that is exactly how it progresses. So just like any other thing in life, a stitch in time is said to save 9. So let's ensure that when we see the early sign, you see a child who has a squinting eye, we need to do something about that. I have also used the picture on the left to try to show how it goes through the inside of the eye, which you don't see. It starts like this normal eye on the left, lower picture. Then it goes to this small one. The cancer is this whitish one. Every other part of that eye remains normal. But this is the cancer. When we don't do anything about it, it goes to become this big until we can no longer see. The whole eye is taken over by the tumor. I mentioned that most of them would have presented before 2 years. I want to show this from the record, the research we did to show 7 years of our patient from 2013 to 2019, during which period we managed 148 eyes of children who had retinoblastoma, which kept increasing from 2013 upwards, the number of new patients now that we manage. If you look at this table before me, you would notice that this first column is talking about age at which somebody first noticed that there was a problem, whether the eye was squinting or that whitish reflex, because they are the earliest signs that anybody would see. Now, out of the 148 eyes, 22 of them, which constituted 14.9%, were noticed before the child was 1 month of age. In other words, those children were already born with the disease. As they were born, they were noticed. After 1 month, up to 6 months of life, another 29%, about 30% of the problems were noticed. After 6 months to 12 months, 10%. If you look at this, what is obvious from this picture is that up to most children would have been noticed in the first 6 months of life. Over 40% of the children were noticed in the first 6 months of life, and the others thereafter. And this is a period when children are still close to families. Well, if it's not a career mama. So family members are usually the first to notice this problem. On the right side, we're being shown that out of these 22 that were noticed in the first month of life, only 3 of them went to see the eye place where they will be. So what happened to the rest, to the 19 of them? People will be praying. Normally we should pray, or we should add prayer to seeking help. God will help us normally with what we are not supposed to do anything about. With what we can do, so it's like we're expecting God to feed us. He has provided energy, life, body, wellness, brain, and we don't work. We want God to feed us, or there is food in our houses, and we say, Lord, oh, I wish I can have rice to eat, because we're too lazy to cook or something. So while we are praying, let's ask for some help so that we will be able to get these children in early enough. We also look at the first 6 months of life. How many of the children had presented? Remember that by the first 6 months of life, about 44% of children who had the disease had been noticed. But if you look at this, only about a half of, in fact, less than a half, 14% had come to the hospital. And that is actually the problem. People not checking in on time. And so it allows the disease to spread from one part of the body to the other. This is also showing the picture of how did they present. What did they come with during those periods when we finally saw them? A lot has happened. In the past, when we were training, almost everyone came with this, where the eye was pushed out, was already pushed out. Most children, that was what we saw. A few of them had this white tissue glow that we're talking about today. But because of some of the things that the Restore Eye Foundation is doing today, some of the educational things we have done everywhere, we talk about it. This one in red here in my graph that you're seeing is that eye being pushed out. As of 2013, only 9 records were found in our hospital when we were doing this review. More than half of them came at that advanced stage. But over time, with what you and I have done, or we continue to do, we continue to have that going down, while coming at a whitish thing in the eye now increased from about 22% in 2013 to 82.1% in 2019. So we have done well, but it is not enough that they come that early. It is more important that appropriate treatment is taken and follow-up, for example, is instituted. It's not enough to come. The beginning is not the important one, but the ending of it. So is there a cure? Why is it important for us to come early? I want to tell us in other parts of the world, developed parts of the world, even in India, over 98% of children who develop, if you take 98 out of 100 children who develop retinoblastoma, they will survive the disease. In Africa, ours is still just about 50%, 1 in 2, 50 out of 100, instead of 98 to 99 out of 100. So why is it so? It's so because what I have put in bold here, they do not come early, treatments are not given promptly or correctly. So if what we're doing today, every one of us who can do something, and we all can do something, is pushed across, our children would also do well and survive this gruesome disease. Why do we treat? The first reason we treat is that we want to save the life of the child. That is our first goal, because you need to have life to have eyes, to have need for the eye. So we look at what is the best treatment that will ensure that the life of this child is saved. Remember, we're dealing with a cancer. If we realize that we can save the life, we then say we want to salvage the globe. Because sometimes the tumor has spread in the globe, but it hasn't come out of the eye. And we may not be able to salvage vision, but we can salvage the globe. But if the child comes early, we'll be able to also preserve the vision of the child, like you probably will see in the course of this presentation. Where can we find help for retinoblastoma? I mentioned because of how early in life the signs come about. Parents and family members, they say grandmothers, are typically the first to notice the glow. But the problem sometimes is they just wish it away. In fact, they can find a good way to say that, alagbara, the child is going to be strong or something. It could be detected during well baby clinic visits when we go for immunization or want to weigh the children or whatever, or pediatric clinic if a child is ill and they are doing general examination, sometimes at family outpatient units, sometimes by the specialist, or during surveillance. Because if I have a child who has retinoblastoma under my care, one of the things we tell the parents is every child you have, once that pregnancy is now about 28 weeks, we want you to be doing regular ultrasound. So we can pick this up even before that child is born, and so be able to institute care immediately. I put a link here. We did a project that helped us to get this website in that has the name of the centers in Nigeria where children's eyes are looked after. At least go to the nearest one to you. If they don't look after retinoblastoma, they will guide you. This is a setup in Kwara State where immunization staff examine children's eye to be sure that they do not have this disease. And imagine 2 children within 6 months when we first launched this program were referred because of retinoblastoma. I want you to take notes. Watch out. Don't allow anybody to think that it will go away or that the child will outgrow it. We have seen that as a reason why people delay. People who have no understanding of the disease, they give wrong information. We are a very optimistic people. We like to believe that things will go away, that somehow it will not be our portion. I want you to know that it's good to check, and if it is not our portion, we will go and give thanks. But if it's our portion, it allows us to be able to manage the disease early, because it is a disease that is life-threatening. This is one disease in ophthalmology, in eye care, where people die because of it. And why? It's going to get worse if we don't do something about it, and it will ultimately take life. We have a camera in some of our centers that can show the disease and convince you whether it is there or not. And I must say that it's an expensive disease to manage. This camera alone is in thousands. The cheapest of which you will get will probably be about $30,000 of dollars. But then, this is a disease in which delay is extremely dangerous. I just use this as an example. That same child you saw, the child already has this disease spread beyond the eyeball. Remember, it's a disease inside the eyeball. Once the eye gets pushed out like this, it is a sign that that is gone beyond inside the eye. After 2 months of treatment, this is the same child. We lost this eye. We lost this child. Because once it was like this, already the brain was affected. We can imagine if this had been picked when it was small, we would have been able to keep the child. It usually responds very well to treatment. And I have these children, I have many of them. This child was managed in year 2007. At age 3, the child is alive. This was retinoblastoma in this right eye of the child. And this is the same right eye after treatment. Of course, in this particular instance, this eye had to go because the tumor had already filled the eye completely. There was nothing we could do at the time to keep that eye, but at least we were able to keep the child alive. Similarly, this one also, because at the time the eye came, it was even already gone. It was shrunken. It had killed itself somewhat, that killed the eye, but it hadn't spread. This girl is now 18 years old. She was managed at about 14 months of life, and the child is alive. This was another child that had tumor in many parts of the eye. You remember I said that you can have it in 9 places. All of these patches you are seeing were where the tumor used to be. The child is alive and is able to read all our charts, except one line. He was reading 6-9 the last time we saw the child. So the child is alive, vision preserved, using laser and medicine because that child was seen early. Do we treat this disease? There are many ways we treat it. We can put drugs in the body. We call it chemotherapy. They are very powerful medications. And typically, in over 90% of the cases, the body will respond well to it. But that alone is not good enough. We need to have other treatments like this one, laser. Using laser, this laser also is also a very expensive piece of equipment. When we bought it back then, it was $48,700. So, but this is not all it does. It treats other diseases, but we use laser. We sometimes use very cold ice. It's not like the ice in the house. We call it cryotherapy. So join. And most recently, this year, we launched a new treatment that we treat a treatable tumor, not the one that has left the eyeball. At those early stages, we go through the thigh and to the neck, to the brain, to directly treat the tumor. So instead of giving drug to all parts of the body that will also be affecting every part of the body, we just go directly to treat the tumor through the brain. Of course, this was done in Nigeria. We did 2 cases in January. We have many patients now. At least I have about 4 patients now who need this. Funding is our problem. That has not allowed us to be able to do for them. But things are getting better. I believe that in another maybe 5 years, we will have an easier way, cheaper way to treat this tumor. I want to say, how expensive is it? I already probably told you it's a bit expensive to manage, but not as expensive as the eye or the life. So typically, if we're not going to, the most expensive for now is the one through the brain. And as it is in Nigeria today, for 3 times that we plan for, the child may need up to $10,000. But for all the other ones, maybe every time they come, we want them to be prepared to spend about maybe 100,000, and they will come minimum of 6 times before we say what we call follow-up. We keep following them up. So what are some of the challenges we have had in managing retinoblastoma in Nigeria and the rest of Africa? People come late. Number 2, religious disbelief or belief of it is not my portion. I am a believer. I am a Christian. The Bible says that secret things belongs to God, but that those that are revealed, they are for us. So things that we have been given knowledge and understanding about, they are for us to make good use of. So when this knowledge and understanding we are given is for us to be able to use to do something to help humanity. So and it doesn't stop us from praying, from asking God to help us. So that tends to make us go late. Or they will be saying the mother, there's one of my patients that they said the mother is a witch. Can you imagine somebody calling the mother of a child a witch? You know, they will be going to all manners of places where they will cause delay. Some of our patients have problems with payments because payment is still out of pocket largely for Medicare in Nigeria. Less than 10% of people are under one kind of insurance or the other. But many insurance will not cover even the cost of care. Not accepting treatment options. Sometimes we have to remove the eye when it's in the best interest of the child. Because if we don't remove the eyes, like you put fire on your roof and you go to sleep. But in some cases, the early cases, we don't need to remove the eye. We hope to preserve the eye and also to preserve vision. The other problem we have is people not completing treatments and people not coming for appropriate follow-up. And so it becomes a problem. Sometimes you are halfway through, then we are calling, you're looking for them, people don't cooperate. They will say the grandmother said the child should not come, nobody in their family, or they will chase the mother away. You know, social issues are some of the most difficult things we have to manage in this. And it's a specialized disease. Without me saying too much, you can see how expensive those things we use to manage the disease. It's not something that can be replicated everywhere because of competing interests in our hospitals. But every hospital can at least guide a child and the caregivers on how best to seek care and get the best of it. We all can do something. That's where I'll be ending this talk today. Everyone listening to me, whether you are a medical person or you are just anybody in Nigeria or wherever you may be, we can do something. For example, if you see it, say it. I have patients who come to the clinic and they say, oh, I didn't notice any problem in my child's eye, but I came to buy things from my shop and say, don't you see that this child's eye is squinting, is 430, is older, they call it different things. Then the mother come. That person who raised the observation has helped that family. Did not give them any money or anything, but has helped them to be able to come early. Advising on where they can go to is another way we can help. Some will even bring the child to the hospital because if they think that the mother is not going to pay attention, they sometimes come on their own with the child or follow the parents with a child. You can refer the child to the correct hospital where the child can be looked after, not to where they will tell you there is no problem. You can help with treatments. We can support, we have this Restore Eye Foundation, for example. You can support that foundation to help care for one child or the other. You can support research efforts that will help us to continue to improve available treatment in our part of the world. Thank you so much for listening to this disease that is very responsive to treatment, but will invariably kill a child if prompt and appropriate treatment is not provided. Thank you so much.
Thank you very much, Prof. That was a fantastic lecture, so succinctly explained. It's very understandable. Even I've learned a few things, even though I'm an ophthalmologist, a few extra things I didn't know before. So thank you so much, ma'am, for the lecture. I'm sure we all enjoyed it and we're all very well educated about this topic. I would like for anyone who has questions to please put it in the chat box or raise your hand a little later. Right now, what I would like to do is to run an introduction of Restore Foundation and tell you what Restore Foundation is all about. So once this is done, then we will take on any questions that may come up. So Restore Foundation for Sight is a non-profit, non-governmental and apolitical health advocacy and intervention organization. We give treatments and education primarily focused on blindness and visual impairment in children, and we basically serve as a facilitator for care. Our vision is to ensure the attainment of full life potential through optimization of eyesight, especially in disadvantaged children, focus on this disadvantaged. And to this end, we're on a mission to restore and improve vision and ocular alignment in children. Our core values are those of empathy, respect, dedication, quality service, and we're dogged about getting good results. Our activities sit on a tripod of education and training. We have advocacy and then intervention activities, both clinical and community interventions. Just as a summary, as part of our education activities, we have free teacher trainings that we do in vision screening for school children. When I introduced the lecturer, I said that she was the proponent of a teacher-led visual screening. So this is the direct adoption of that, the concept that you get teachers to educate them to know how to do a basic screening, to vision screening for children. That way, the class teacher is in a position to pick out children who are visually impaired. This is the only way children will get detected early and seek early treatment. Over the last 16 months, Restore Foundation has directly trained 848 teachers, which translates indirectly in an estimation to 4,200 on the average. One person trains 5 other teachers in school. So, and we've done this for about 389 schools in batches under the aegis of different organizations such as NAPS, the Nigerian Association for Proprietors of Private Schools, League of Muslim School Proprietors, on Army Education, as well as a group of schools that are internationally recognized to be in disadvantaged, usually riverine areas, called AFED, Association for Formidable Educational Development. So just a few visuals to bring home what the sort of things we do. So we have seminars and practical workshops where teachers are put through the paces of how to test. And we believe that this adds value to education and educators. This was the Army. So just about every community we go to, we take the opportunity to do this. Now, community intervention activity.
Hello, your slide is not on.
Pardon?
I need you to share your slide. Share your slide.
I'm sharing my slides.
We can't see it.
You can't see it, man.
Oh, my goodness. Okay, I'm so sorry. I thought I was doing that. Can you see it now?
No.
Okay, let me just see what I can do. Okay, sorry, just give me a moment. Let me just see what I can do here. Yeah. Okay, sorry, I'm just trying to get my orientation. I don't know why.
Should I share it for you? Should I share the slide I have with me?
Okay, let me just end the show. Okay, hold on. I think I'm now where I should be. I need to be able to see your slide. Okay, go ahead and share what you have. Okay. Well, I hope I can see. Are you sharing now?
Yes. Okay. Can you all see? Prof, can you see the slide?
Yes,
I can
the slide
see it.
is on.
Okay.
You can see the slides now.
Okay. Okay, so that means you have to move the slides for me, yeah?
Okay. So this is the teacher's training.
Right. So the teacher training, Dr. Kiremi, can you just, okay, yes. So this is it. So this is a teacher training, different views from our teacher training activities. Yeah, so let's go forward. Yeah, keep moving forward. Right, so these were the Army schools, and then Yes, more and more of the teacher training. Yeah, next slide, next slide. And then our community interventions. Last year we were in my community. Makoko is the biggest floating, slum in Nigeria. And we, over a period of 5 days, we saw 1,700 children and examined their eyes. And we were able to, next slide, and we were able to give out treatments, instant treatments. So this is a panoramic view of the sort of environment that it is. Yeah, keep showing the slides. So basically riverine areas, deprived, no poor access to healthcare. And so this is a sort of thing. These are just pictures from the program, all the eye screening. So we had vision testers, and then we examined eyes and we gave treatments instantly. Those who needed glasses got their refractions, fitted with frames and got the glasses made. Those who needed drugs were given drugs. Another community we visited, Agboyi community in K2, again, another riverine community, 790 children over 4 days. Next slide, please. Next slide. Yes, so this is, again, a panoramic view. So we had to be voted into the community. And so these are children waiting to be seen, scenes with children being examined and refracted, and then subsequently, yeah, next slide.
Yeah.
Yes, children taking away their eye drops and whatever the other devices that we needed to give them. Again, Ebutemeta, this was recent, February this year, where we saw over 1,000 children, again, a 4-day activity. Again, as usual, yeah, just run the pictures.
Okay.
Yes, so as usual, just scenes of children waiting to be seen and, examined and treated. Yes, so this is it. That's Team Restore, made up of ophthalmologists, ophthalmic assistants, and non-medical people as well. Now, this is our next project coming up next week, really. So for a 4-day period, we'll be in Ikorodu, a long stretch of community, again, along the riverine areas, and where we would see, children, again, in much the same way as we've seen others. We do community eye care for disadvantaged groups of people. Next slide. So we saw albinos. We decided to take on the albino community. And so last year we saw 123 children over a 3-day period. So the program was advertised under the aegis of the Albinism Awareness Society. So we're able to see them. And again, we carried out an extensive eye care program for them. Yeah, so this just seeing children being, they were vision tested, they were seen, complex refractions, but we're able to get the job done. And so again, we are thinking about orphanages. So we started our orphanage programs. Yes, let's move beyond the albinos, please. Okay. Right, so orphanages, that's another disadvantage, of children. And so we've started our orphanage programs. The objective of seeing children in orphanages is to provide the same high quality vision testing and eye examinations and treatments for children in orphanages and their homes for vulnerable and abused children as well. And their carers as well are not left out. We provide free eye medication, glasses, and other optical devices. And we also undertake sight restoring surgeries, all free of charge to aid them. We also train the carers in vision testing, and we give them free vision testing kits so that they can continue to examine children that come through and follow up on children, already in their care. And we hope to be able to give children who are people in orphanages, free treatments, from Restore Foundation going forwards. Okay, next slide. So in the last 3 weeks, we started our orphan care program 3 weeks ago. We've seen 197 children from 9 orphanages, about 61 of their staff examined. We've given out 98 free eye drops and ointments, 22 free pairs of glasses. And then, like we said, we don't leave the carers out because we need to incentivize them to be nice and cooperative about it. And so we were able to dispense 28 reading glasses, simple reading readers, free of charge to the staff. And so we have 86 orphanages to go, but we're on the journey. So we'll keep going there one after the other. We have clinical interventions, briefly. Yeah, keep going. Clinical interventions, next slide. So again, this is a typical child, miserable before cataract surgery. And then this is a huge transformation of the same child after cataract surgery with an acceleration of developmental milestones. This is, the next child is a child with a squint. And so you can see the picture is evident before surgery, after surgery, better alignment, better vision, and better performance in school. And then the next one is not a surgery, just what we call amblyopia therapy. Some children have good vision in one eye and low vision in the other eye. So these are the kind of therapies that we use to attempt to raise the weaker eye to become almost as good as the better eye. So yeah, next slide. Right. So education activities, an example of this, the first one, this is the 5th in the series of our public education webinars. The first one was about cataracts. The next one is about, retinopathy of prematurity. That's it, by Dr. Karim Musa. The next one handled screen time and myopia in children. And then again, another angle to spectacle use. Next one, please. Yeah, so spectacle use in children, and this is today. So this is the 5th in our series of public education webinars. Yeah, next slide. Right, so in a few months that we've been actively working, we've given out, summary, this is a summary, over 3,000 free medications to disadvantaged, 884 teachers trained in vision screening, 636 pairs of free and or highly subsidized pairs of glasses, and 96 children have benefited from free or highly subsidized eye surgeries, usually cataract surgeries and screen surgeries as well. And so, yeah, next slide. Yeah, so we're poised to do more. I mean, we've barely scratched the surface. We know there's a lot more work to do. And so we want to strengthen everything we're doing right now and keep going and going. We leave no child behind. You know, I'm borrowing a phrase from my mentor, Professor Pupola, leave no one behind. So join us in this effort, support us any way you can. Yes, next slide, please. You can check us out, it's our website, see what we're up to. www.restorefoundationng.org. Also, you can send us a mail on our Gmail address. You can call us on 090-777-22550. If you know a child who is truly disadvantaged financially, send them to Restore Foundation for Child Sight. We have a Facebook address, Facebook, that's a Restore Foundation NG, and then Instagram Restore Foundation _NG. Thank you for your time, and apologies for the technological glitch. Some of us are still, we're still trying to measure up to the Gen Z. Thank you so much. So at this point, we would like to handle any questions. Okay, so Prof. Ma, I think I have, I can see a question in the dialogue box. Somebody says, thank you for the lecture. Please, what is the tumor regression pattern in retinoblastoma? That's a question.
Okay. Thank you very much. The tumor regression pattern in retinoblastoma is that first thing, the larger the tumor, the faster is the regression you would first notice. And this regression, about 50% of the tumor volume will be down after the second course of chemotherapy. We usually give chemotherapy every 3 weeks to 4 weeks. I hope you are hearing me.
Yes, ma'am.
Yes, ma'am.
Okay, maybe I should take off this video. Not to mess up. Number 2, we have 4 regressions, peak regression, which is the commonest one because most of the tumor that our children present with, distinguishing retinoblastoma from many tumor in the eye is it has calcium. So it will regress leaving calcium. So that is called calcific regression. We have the next one that is called fleshy regression. The fleshy regression, the tumor will still be looking like there is tumor, but it will not be active. For example, one of the pictures I showed, sorry, I had to move from laptop to phone because my network was misbehaving. Maybe I'll go back to the laptop. You will see that the blood vessels will be dilated as though working over time. But once the tumor has regressed, even that bit, the vessel will thin out, it will become normal. We have the one that we call mixed form of regression. It will have both the calcific and the fleshy regression. And then we have the most loved regression. That is a flat scar. That means when the tumor has regressed, it will just leave a flat scar, no calcium, no fleshy. That's what we all want, but usually it doesn't happen except in very small size tumor. So that is the pattern of regression that we have in retinoblastoma. In other words, about 50% of the volume of the tumor would be down by the second course of chemotherapy, correct chemotherapy given in appropriate dosage. That is what you would say. And thereafter, it reduces gradually. That's why we need to add those other focal treatments type that would help the tumor. We no longer, almost as a, for intraocular retinoblastoma, radiotherapy is not one of those things we use. Once we say a patient needs radiotherapy, it means it's a bad scenario that we are dealing with. Thank you very much for the question. Hello?
Yes, ma'am.
Yes, thank you, ma'am.
Okay.
Thank you, ma'am. Yeah, so I have another question that says, are medical practitioners in other fields contributing to the discovery at early stages? And what more can be done within the hospital for early discovery?
Thank you very much. One of the things we can do is to ensure that we have policies in our hospital that ensures that children's eyes are examined. One, let's talk about radiology, for example. Almost every woman who is pregnant does an ultrasound. The sonologist needs to know that the eye is part of what they should check out because it shows, even in utero, in those ones who develop it early. Remember that in the course of this presentation, I mentioned that in the first month of life, about 14.9% of the children already had the tumor. That's a huge number. That's 15%. Those could have been detected via ultrasound from the utero. And that allows those children to be picked early and to have early treatment. Then when a child is born, before they are discharged, when we were training, before the child was discharged back then, a pediatrician will examine the child thoroughly. This should be part of it. While baby clinic, this should be part of it. Hearing, eye examination should be instituted nationally as part of what should be examined during our well baby clinics. And it's not rocket science. And of course, when children are healed from whatever, some of them are accidentally also picked up by the family physicians who look after a whole family. So there are a whole lot of people. You have the antenatal clinic also where our nurses can at least give the kind of health education that we have given today. We pray that your child will be born well and healthy, but sometimes they come with challenges which may affect the eyes, as it may affect other parts of the body. It may show like this. If you come early, nobody will even know your child has problem because it will be well treated and all of that. So everybody can do something. Because the same everybody, they are just ones who also tell the patient's relation to say, don't worry, the child will out.
Yeah.
Go on. Grow it. So everyone should. Thank you very much.
Okay, thank you very much, ma'am. I would like to ask myself, ma'am, if a person has a child or if there's been a child with retinoblastoma from a family, should they be worried about the other children, the siblings of this child? Should they be worried?
Very important question. They should be worried. I'm very much worried. The reason is that I talked about how it comes about. I said it's about the gene. What makes us who we are, the basic unit of our heredity. About 40%, 4 out of 10 patients who have retinoblastoma will have it in both eyes. And all such done to the child somehow, it can be transmitted to the offspring of parents. So if those parents are still going to have this child, she's now 8 years old in the 2 eyes. Because of the counseling we give, the mother knew that this disease could have been
Hello, Prof.
in fact was inherited. So when our home brother had a kid, our own child was 8 months when we saw, but the information we gave her made her to look out for it when our own brother had a child. And so we were able to save that one much better than our own child. Now, unfortunately, I saw this woman this last week in clinic. She had a child after the child is now 2 years. Because she thought that by using her own eyes to look, she would know if there was retinoblastoma. So she was using her eyes to look for the glow. Instead of allowing us to do the surveillance for her, she was advised previously. The glow did not come until our own child is now, our own other child is now 2 years old. So when I saw this child, I was very distressed because she had all the information to have made that cancer to be detected so early, because the cancer in that child has completely filled that eye. It wasn't until then that she and her husband now saw it. So if we have a child who have retinoblastoma, there's something we call surveillance that must be done by the family, by the hospital. Thank you very much.
Okay, thank you.
If we were to be doing genetic study, not all children will probably need not all family probably need this, because we can look out for the gene in the child that had the disease. If the retinoblastoma gene is not abnormal, so we will know if that's one of these ones, usually the one that happens in only one eye, that's okay, may not be heritable. But even if it's one eye and it has now affected 2 children, then it's also heritable, because 15% of those affecting only one eye are also heritable. You will see that the one I presented from my own center showed that 50% of our cases were in both eyes. That happened because we are a referral center for the country. So, but on the average, it's 40% bilateral, 60% unilateral. That is, bilateral means both eyes, unilateral means one-sided, one eye. Thank you.
Okay, thank you very much, ma'am. I can't see any other question right now in the chat box, but I think I would like to know about, you mentioned that retinoblastoma can start in antenatal life, which means the developing baby already developing retinoblastoma. Is this a sort of thing that an ultrasound in pregnancy might detect? Might an ultrasound detect that there's a tumor in that unborn baby's eye?
Yes, I said that, or maybe my network wasn't good. I mentioned that already. I said that when we're talking about who has, what other health workers might do some, I said the sonologists who does the, what do they call it, ultrasound for these mothers, should know that from about 28 weeks of life, they should look at the eye as they check the other parts of the body. Because if we detect it in utero, in the womb, that child can be, we can ensure the child comes down at 34 weeks. You know that we also don't want retinopathy of prematurity. And so start to manage retinoblastoma so that the child will have a better chance as having the eye saved. One of the children that I have managed was just a 3-week-old baby, you know, so we see them that early. And I also have had a 9-year-old affected by retinoblastoma in my own. Okay, somebody said, there's a question here. Can retinoblastoma develop later? I mean, what's the question?
Yes.
In children
later
who did, Yes, that's what I said. Retinoblastoma can occur anytime. For most people, over 90% of retinoblastoma occurs up to 5 years of life. And some, about 49 cases have been reported in adults. I mentioned that the oldest child I have managed was a 9-year-old child with retinoblastoma. So if the child does not have in the first 3 months of life, they can still have it at other times. The important thing is to be on the lookout to check. Is treatment possible inside the womb? Not yet, because of the type of treatment that we give. The treatment is directed directly on in the eye. And remember that we give this treatment every month, even the one through the brain, it is every month for 3 times. So we haven't reached that level. Maybe we will, who knows? Everything is possible. Over time, maybe we will get there, but not yet done in the world now.
Okay, thank you very much, ma'am. I don't see any other questions in the chat box, and I don't see any hands
I did
up.
put a question on the chat box, please. Maybe you didn't see it.
Oh, apologies. Please go ahead and tell us.
My
Ask
name is
right.
Sam. I'm a professor of hematology, long retired. I want to thank you for this excellent presentation and also for the information about your Restore Hope. My question was 2 parts. I know you are an NGO. I'm wondering whether there's any plans of extending this your services to other parts of the country. It suggests, the presentation suggested that you are mainly in Lagos. Secondly, although you are an NGO, are you getting any cooperation whatsoever from governmental agencies, and in what form? Thank you very much again for the excellent show.
Okay, thank you, sir, Prof, for your question. Just to clarify, like you said, we're an NGO and we're facilitators for care. And so if we did come across a child with retinoblastoma, we would be sending to where they get the very best attention. That child may need financial assistance from the NGO, and that's where we come in. But for instance, clearly from the presentation, you can see that Professor Pupola has a fantastic setup for retinoblastoma in her center. So typically when we see retinoblastomas, it's a very specific disease that needs a specific kind of specialist and treatment. And so it's cancer, we don't dilly-dally with it. I would be sending directly to an oncologist, to a pediatric oncologist, and Professor Pupola is no better person, as far as I know, to send to. As for government, maybe I should let Professor Pupola answer the second part of the question, where you're talking about government input, because she works in the federal center. So I think she's probably in a better position to answer that one. Thank you, sir.
Prof, sir. Good evening, sir. I just want to say thank you for being here. We really appreciate and recognize you. You are a giant. Thank you so much, sir, for attending the session. What we have done, and I want to thank Dr. Halimi. She has always been passionate about pediatrics. She is one of those, my younger ones, and I thank her for all that she's doing. In Ilorin here, because we have this childhood child protection law that was passed as far back as 2013, early 2014, that every child should have an eye examined. The government did not quite back this up financially, as you will not be surprised. But we have a lot of good ways. So we started pushing, like you said, the sort of things that you are saying here. And fortunately, over those years, we had a lot of support from individuals, from USAID, to train teachers, create vision corridors in school, pretty much like what Restore Eye Foundation is doing now. And we're hoping that many people will do it. While we were doing that work, we worked in 6 states, in Kwara State, in Osun State, in Edo State, in Adamawa State, in Brennan Kebbi. You know, we are trying to do that. We are hoping that it will go around the country. And so I know Prof will definitely have a lot of influence everywhere. And Alima is doing this in Lagos State. I know that also some other groups did a number of things in some other states like Kaduna or Oyo, Zamfara, Sokoto State, where Professor Natsir, I think I saw him on the chat. I don't know if it's the same our Natsir in Sokoto. So we have these things here and there, but certainly we need the government to actually make this an important thing for every child. NGO will continue to do their bit, but certainly the government will even be able to do more because so much resources is with the government. So, sir, you would help us wherever everybody doing a little here and there, the whole country will be covered. Thank you so much, sir.
Okay. All right. Thank you very much, Prof. So we've all had a very educated evening. We're privileged to have a giant like Professor Ademola Popola giving us, there's no better person. I think everybody now agrees with me to talk about retinoblastoma. And thank you very much, ma'am, for finding time to honor our invitation. And we know that your schedule is super, super tight, you know, wearing so many hats. So may God continue to bless your work. More grease to your elbow, ma'am. Thank you so much, everybody, for turning up to listen to this lecture. And we hope that you can also take this information to everybody you know. I'll be happy if you want to have the recording. This is being recorded. If you want a recording, I don't mind. I'd freely give it out. It's for public education, and we're hoping that this can have an impact and let us save more sites, save more life. Thank you so much for everyone. So I bid you a good evening. Look out for the next in the series of our public webinars. We will announce in due course, probably in another couple of months. We'll find another stimulating topic to address. Thank you so much. Thank you, Prof. Ma. We're really very grateful.
Bye-bye.
Have a good evening. Thank you.